I appreciate the honor and privilege to introduce Dr. Loeys-Dietz this morning. He is the Victor A. McCusick Professor of Pediatrics at the Department of Genetic Medicine at Johns Hopkins University School of Medicine and an investigator at the Howard Hughes Medical Institute. He performed his undergraduate training in biomedical engineering at Duke and received his doctorate, his MD from the Health Sciences University of Syracuse. He then did clinical and research training in pediatrics, pediatric cardiology, and genetics at Johns Hopkins. He heads a multidisciplinary clinic for the diagnosis and management of individuals with heritable forms of cardiovascular disease, with special emphasis on Marfan Syndrome and related connective tissue disorders. He directs a group of dedicated molecular biologists focused on improvement of the lives of individuals with Marfan Syndrome and related disorders through the development of novel diagnostic and treatment strategies. And his research is focused on elucidation of the etiology and pathogenesis of connective tissue disorders that involve the cardiovascular system. Using a human genetics approach, his groups identified the genes responsible for multiple syndromic presentations of aortic aneurysm, including Marfan syndrome and Loeys-Dietz syndrome, as well as Schmitz and Goldberg. His lab is best known for in-depth mechanistic studies that involve the creation and characterization of animal models. His work has firmly implicated the TGF-beta signaling pathway in aneurysm progression and has revealed many unanticipated treatment strategies. He's won multiple prestigious awards, including the Kurt Stern and Mentorship Awards from the American Society of Human Genetics, the Taubman Prize for Excellence in Translational Medical Science, the Harrington Prize for the American Society for Clinical Investigation, and the Harrington Discovery Institute. He's an inductee of the American Society for Clinical Investigation, American Association for the Advancement of Science, Academy of American Physicians, National Academy of Medicine, Association of American Physicians, and the National Academy of Sciences. Beyond that, as one of the co-leads of our coaching and mentoring program here at Stanford, I'm particularly interested in the fact that he has mentored 75 doctoral and postdoctoral mentees, many of whom have gone on to rather distinguished careers on their own. And finally, he's published over 285 peer-reviewed papers that seem to increase every week or so, and published 25 book chapters. So I'm highly excited to hear what Hal has to share with us today. And with that, I'll turn it over to you, Dr. Dietz.
Thank you, Tom. Thank you for that really kind introduction. It's my pleasure to join you today. As was mentioned, my focus, some would say obsession, for my entire career has been Marfan syndrome. Perhaps more generally, aortic root aneurysm. So aneurysms are considered to be the cause of death in about 2% of all people in industrialized countries. The majority of genetically imposed aortic aneurysms occur as discrete fusiform lesions of the aortic root with rapid taper to a more normal aortic dimension in the distal ascending aorta. Common presentations of aortic aneurysm, like abdominal aortic aneurysm, have been notoriously difficult to model and study because of their complexity. So many years ago, we made the deliberate choice to begin our analyses with rare Mendelian and therefore experimentally tractable presentations of aneurysm, and then an exploration of the relevance of findings to more common but complex presentations. This strategy also allowed us to make animal models of these conditions, and we will rely heavily on them for the rest of the talk. I wanted to convince you early on that these animal models, these mouse models, nicely recapitulate the aortic root aneurysm phenotype, again with rapid taper in the more distal ascending aorta. Also, it's notable that these aortic aneurysms uniformly show this thickening of the aortic wall with dense deposition of collagen, which will become relevant to mechanisms that we'll speak about in a moment. So over the course of the last 2 decades or so, there's really been an explosion in information regarding the genetic causes of thoracic aortic aneurysm. The genes fall into three large categories, those that relate to perturbations of the extracellular matrix, those that relate to alterations in the machinery that regulate vascular smooth muscle cell contraction, and those that relate to signaling of a pervasive signaling pathway called the transforming growth factor beta signaling pathway. And we initially began our study. Well, you can broadly categorize the phenotype caused by these three different classes. For example, extracellular matrix related disorders tend to be syndromic and show more widespread arterial aneurysms. The vascular smooth muscle cell related conditions tend to be non-syndromic with thoracic aortic aneurysm and dissection. And once again, the TGF beta related conditions tend to have syndromic presentations with predominant root aneurysm, but also the potential for aneurysms elsewhere in the arterial tree. So our studies have initially focused on Marfan syndrome, which many of you know is a systemic disorder of connective tissue with dominant inheritance and a prevalence of about 1 in 5,000. Syndrome is highly variable with cardinal features in the ocular, skeletal, and cardiovascular systems, including dislocation of the ocular lens and overgrowth of the long bones, but most importantly, progressive dilatation of the root of the aorta that essentially will lead to aortic tear rupture and early death if left untreated. In 1991, we were able to use a traditional positional candidate approach to show that mutations causing Marfan syndrome occur in the gene that encodes the connective tissue protein fibrillin-1. So what did we know about fibrillin-1? We knew that monomers interact to form complex extracellular structures called microfibrils, and that these microfibrils cluster around the maturing ends of an elastic fiber during embryonic growth. The simple spatial and temporal relationship led to the rather firm belief that you need a lattice of microfibrils to make an elastic fiber during embryogenesis. And if you think about it, this boded poorly for the development of treatment strategies. It suggested that children with Marfan syndrome are born with inadequate elastic fibers, and that they therefore have an obligate structural predisposition for their tissues to fail later in life. Essentially, there's nothing you could do after birth. But while many of the manifestations of Marfan syndrome were reconciled by this so-called weak tissues model, there were other manifestations that were less well explained by this model, including overgrowth of the bones, as shown by the fingers in this severely affected child, or the long arms in this young man on the left. Also, the craniofacial features of Marfan syndrome are hard to explain based upon weak tissues, as is the low muscle mass and low fat stores that are so characteristic of this condition. So over the course of about 5 years, we and others developed the realization that microfibrils composed of fibrillin-1 serve other important functions other than simply acting as structural elements within the extracellular matrix. And importantly, that microfibrils can bind to the large inactive complex of the multipotential cytokine TGF beta. We were also able to show that in the context of reduced microfibrils, as in Marfan syndrome, there's excessive amounts of free TGF beta in the local tissue environment that can then interact with its cell surface receptor and set in motion an intracellular signaling cascade that includes phosphorylation or activation of SMAD2 or SMAD3 that partner with SMAD4, translocate to the nucleus, and mediate transcriptional responses to TGF beta. Using mouse models, we were able to show that high TGF-beta signaling that was observed in many tissues had phenotypic consequences, including developmental emphysema, progression of aortic aneurysm in postnatal life, thickening and dysfunction of the mitral valve, or skeletal muscle myopathy, because each of these findings could be attenuated or in some cases even prevented by treating fibrillin-1 deficient Marfan mice with a TGF-beta blocking antibody. They still had reduced amounts of fibrillin-1, reduced amounts of microfibrils, and yet these phenotypes were improved simply by blocking TGF-beta. Now, around this time, we wondered, is there a drug, even better, an FDA-approved drug, that might mimic this protective effect? And our attention turned to a class of antihypertensive agents called angiotensin receptor blockers, or ARBs, with one example being losartan. This had been shown to attenuate TGF-beta signaling in rodent models of chronic kidney disease. So how does losartan work? Well, angiotensin 2 signaling through its type 1 receptor called AT1 can increase production of TGF-beta ligands, receptor subunits, and activators of TGF-beta like thrombospondin-1, which can culminate, in increased TGF-beta signaling. In contrast, angiotensin 2 signaling through its type 2 receptor is thought to antagonize many of these AT1-mediated events. So we reason that selective blockade of the AT1 pathway with drugs such as losartan might be beneficial by reducing expression of TGF-beta effectors, and also perhaps by shunting signaling through the AT2 pathway. We went on to do a clinical trial in mouse models of Marfan syndrome, where we compared the performance of losartan to that of the beta-adrenergic receptor blocker propranolol that reduces blood pressure and heart rate, but does not alter TGF-beta signaling. As you can see, propranolol led to a relative reduction in aortic root growth rate in Marfan mice, but this did not associate with any change in aortic wall architecture. It's still very thickened, congested with collagen, with fragmentation of elastic fibers, and there's still high ongoing TGF-beta signaling as shown by nuclear accumulation of phosphorylated SMAD2. In contrast, no observer could distinguish losartan-treated Marfan mice from their normal or so-called wild-type littermates by any histologic or functional parameter, including complete normalization of aortic root growth rate and preservation of aortic wall architecture, with direct evidence of reduced TGF-beta signaling in the proximal aorta. We felt compelled at that time to try this strategy in a subset of children with the most severe and rapidly progressive form of Marfan syndrome. As you can see, these children show unrelenting growth of the root of the aorta, despite maximal treatment with beta blockers and/or ACE inhibitors, reaching surgical endpoints or death in early childhood. These are the growth curves of the first two such children that we treated with losartan, showing a very striking and sustained plateau in aortic root growth rate upon addition of losartan to pre-existing therapy. In total, we treated 19 such children, and on average, we saw about a 10-fold reduction in aortic root growth rate once losartan was started. Now, there have been many other clinical trials of losartan in individuals with Marfan syndrome. Early on, Chu et al. In Taiwan performed a study very similar to ours in severely affected children. And they saw about a 9-fold reduction in aortic growth rate upon the addition of losartan. Pease and colleagues looked at a broader spectrum of children with Marfan syndrome and saw a very significant reduction in normalized aortic growth rate and aortic root Z-score over time when losartan was added to the medical regimen. And Groening and colleagues in the Netherlands studied adults with Marfan syndrome, and they saw that both in adults without prior aortic root surgery and even in adults with prior aortic root surgery, that losartan led to a significant reduction in the growth rate of the aortic root and or the more distal ascending aorta. Now, a large study performed in this country by the Pediatric Heart Network had somewhat more nuanced results. It compared beta blockers to losartan in children and young adults with Marfan syndrome. Both groups showed very low rates of aortic growth and a decline in aortic root Z-score over time, a significant reduction, but there was no difference between the groups. It appeared that both beta blockers and losartan were equally good at protecting the aorta. An important consideration is that the dose of atenolol was somewhat atypical in this study, up to 4 milligrams per kilo per day, or twice the upper limit suggested by the FDA for the treatment of hypertension, whereas losartan was capped a little bit below the FDA-approved dosing. What's notable is that, again, in both groups, the aortic root growth rate was much less than that previously observed in untreated pediatric patients with Marfan syndrome, or even in patients with more typical dosing of beta blockers. Two new large prospective trials have now shown significant protection afforded by ARBs, either losartan or irbesartan, in people with Marfan syndrome. And most recently, there was an interesting meta-analysis that was reported that included 7 prospective trials in over 1,500 patients. The ARB-treated group showed slower, root and ascending aortic growth when compared with placebo. And then when ARBs were added on top of beta blockers, there was a very significant decline in aortic root growth rates compared to beta blockers alone. The Dutch group has now revisited their patient population after 8 years, and we're able to show that first, the benefit of losartan was sustained over controls, and that this also had clinical consequences. There was a reduction in aortic root replacement, operation beyond the aortic root, aortic dissection, and all-cause mortality in individuals that had received losartan. So it appears from these data that both losartan and beta blockers have their place in the treatment of these conditions. I think the new challenge is to understand the likely best treatment regimen for individuals rather than for populations. So still a lot of work to do. So back in the early 2000s, my postdoc, now good friend and colleague, Bart Loeys, and I recognized and described a new aortic aneurysm syndrome that had many features in common with Marfan syndrome: curvature of the spine, pectus deformity, arachnodactyly, aortic root aneurysm, but also the potential for many unique features like hypertelorism, a cleft palate or a bifid uvula, craniosynostosis, clubfoot deformity, and multiple forms of congenital heart disease. Most importantly, these children showed a diffuse and aggressive arteriopathy with widespread arterial tortuosity, aneurysms not just at the aortic root, but at many different locations throughout the arterial tree, and aneurysms that tended to rupture at smaller dimensions and younger ages when compared to Marfan syndrome. We at Hopkins have now had the privilege of caring for over 500 families with this condition that's referred to as Loeys-Dietz syndrome. So we, as you might imagine, attempted to define the molecular basis for Loeys-Dietz syndrome. Over the course of the following 7 years or so, we and others defined the etiology for many presentations of this condition. And informatively, all of the genes that are capable of causing this Loeys-Dietz syndrome phenotype directly relate to effectors of the TGF-beta signaling cascade, including the genes that encode both TGF-beta ligands, TGF-beta 2 or TGF-beta 3, the genes that encode either subunit of the TGF-beta receptor, and the genes that encode the intracellular signaling intermediates SMAD2 or SMAD3. We also had strong desire to understand the cause of a rare condition called Sprintzen-Goldberg syndrome, which shows virtually all of the craniofacial, skeletal, cutaneous, and cardiovascular features of Loeys-Dietz syndrome and Marfan syndrome, with the added feature of highly penetrant developmental disability. And we were able to show that Sprintzen-Goldberg syndrome is caused by mutations in the Sloan Kettering Institute proto-oncogene SKI, whose major role is to suppress the TGF-beta transcriptional response. So Elena Gallo and Dave Locke went on to make mouse models of Loeys-Dietz syndrome by knocking mutations into the TGF-beta receptor genes. We see the clear signature for high TGF-beta signaling in the root of mice with Loeys-Dietz syndrome, as shown by phosphorylation of SMAD2. Elena was able to show that these mice are extremely responsive to losartan, that there's full suppression of aortic root growth, and also preservation of aortic wall architecture. And in this context, these protective effects were not achieved by beta adrenergic receptor blockers such as propranolol. Ben Kang went on to make multiple mouse models of Sprintzen-Goldberg syndrome. These mice show the craniofacial and skeletal manifestations of the disease and also show clear predisposition for aortic root aneurysm. As you might expect, you see that there is high expression of the TGF-beta target genes in the aortic root of Sprintzen-Goldberg syndrome mice, shown in green, compared to wild type or normal litter mates, shown in blue. And not to belabor a point, but Ben was able to show that ARBs like losartan were able to dramatically suppress aortic root growth and preserve aortic wall architecture in mouse models of Sprintzen-Goldberg syndrome. So taken together, these data suggest a broadly relevant mechanism, that is TGF-beta, and treatment strategy, that is ARBs, in syndromic presentations of thoracic aortic aneurysm. A really good question is, can we do better? So, the old school evidence-based medicine asks what works best for the average patient with this problem. The new frontier, so-called precision medicine, asks what will work best for this person sitting in front of me. And I think in the field of aortopathies, we're just starting to be able to make meaningful contributions to precision medicine. In the context of aortopathies, diagnosis matters. So Sprintzen-Goldberg syndrome shows low incidence and severity of vascular disease. The problems focus at the aortic root. We image intermittently and reserve medical management unless specifically indicated, unless someone shows an aneurysm that's getting bigger over time. Marfan syndrome, on the other hand, shows high incidence of aortic root aneurysm that tends to follow the rules that in general, aneurysms can get to be about 5 centimeters in adults or older children. We image about yearly and initiate medical therapy early. We image the entire aorta in adulthood or after root surgery. The Loeys-Dietz syndrome in general is more aggressive with aneurysms throughout the entire vascular tree and dissections at relatively small dimensions. It depends on what gene is involved. The average severity varies between types, with TGF-beta receptor gene variants tending to be most severe, and SMAD2 variants tending to be least severe, but there are exceptions even within those groups. Root surgery, we believe, should occur less than about 4.5 centimeters in all types, and less than about 4 centimeters in Loeys-Dietz syndrome type 1 or 2 due to receptor mutations. We use other information such as family history or prior knowledge about a specific mutation to guide our decisions, but generally use aggressive use of medications and widespread MRA imaging about every 2 years that extends from the head through the pelvis. Now, we're starting to get even more specific. We've learned that there are particularly severe mutations that should prompt even more aggressive management. For example, in Loeys-Dietz syndrome type 2, there is a specific mutation at arginine 528, changed to either histidine or cysteine, that happens to be the most common recurrent mutation causing Loeys-Dietz syndrome, and unfortunately also the most severe mutation causing Loeys-Dietz syndrome. We've seen 19 unrelated people with this mutation, all required root surgery in very early childhood, all required a second surgery, generally for ascending or subclavian aneurysm, pseudoaneurysm, or dissection. Half had a third surgery, many a fourth, and fully 1/3 have died during early childhood, most frequently due to type B dissection. The oldest living patient with this mutation, she's now in her early 20s. So really a red flag that when you see this mutation, it may be more appropriate to take aggressive action at the time of the first intervention, perhaps consideration of not only repairing the root, but also the ascending aorta into the hemiarch, and maybe a full arch repair would be indicated. Here's an example of how fast new things can evolve. So this is a child with that severe mutation. You can see in 2016, at the age of 11 years, there is no aneurysm, but 1 year later, a massive aneurysm has evolved in the absence of trauma or any other definable inciting event. So underscoring the need for close imaging. So up until this point, I've focused on so-called SMAD-dependent or canonical TGF-beta signaling. But it's also known that ligand-activated TGF-beta receptors can stimulate so-called non-canonical pathways, prominently including the mitogen-activated protein kinases JNK, P38, or ERK. It's also known that angiotensin II signaling through its type 1 receptor also stimulates MAP kinases, prominently including ERK. So we decided to look at these alternative pathways to see if they were perhaps contributing to disease progression in Marfan syndrome. We were really startled to see the extent of excessive activation of ERK in the proximal aorta of Marfan mice when compared to their wild-type littermates. At this point, we didn't know if ERK was a driver of disease or simply a marker of disease. To test this, we gained access to an orally bioavailable, highly potent and selective inhibitor of ERK activation called RDEA 119. And we're thrilled to see that it was every bit as effective as losartan in suppressing abnormal aortic growth in our mouse model of Marfan syndrome, and that this indeed happened in association with very potent suppression of ERK activation in the aortic wall without any effect on any of the other signaling cascades under consideration. So we learned that ERK activation was dependent on both AT1 and TGF-beta in this context, And we could conclude that ERK is indeed a driver of disease. We then sought to use this information to try to address particularly underserved or vulnerable patient populations. One such group is women with Marfan syndrome who choose to become pregnant. They show a high risk of aortic tear and rupture in association with pregnancy that has historically been attributed to the high hemodynamic stress associated with pregnancy. But it seemed odd that many of these events, in fact, the majority, were occurring within the weeks to months after delivery, and that this risk was not altered by cesarean section or antihypertensive agents. So Jen Habashi in the lab asked what initiates toward the end of pregnancy, is maintained after delivery, and might synergize with some of these signaling events that we had defined. And the hypothesis that came to mind was the hormone oxytocin that's needed to initiate uterine contraction and milk letdown. Its release peaks at the end of pregnancy and is sustained during breastfeeding. And the receptor is upregulated in the aorta in response to pregnancy. And we became really excited when we learned that the mechanism by which oxytocin stimulates peripheral tissues is through, ERK activation. So we needed a model to test this hypothesis. And our colleague Francesco Ramirez had created a severe mouse model of Marfan syndrome that showed essentially 100% death due to aortic dissection within the first 30 days after delivery. These mice were not dissecting their aortas leading up to or at the time of delivery. This was a very different performance from this mouse line when never pregnant, shown in black, or male mice with Marfan syndrome, shown in red. So we next asked the very simple question: what would happen if we allowed these mice to become pregnant, allow them to deliver, but then take the pups away right after birth to prevent lactation-induced oxytocin release? And the answer was that that simple manipulation transitioned survival from about 10% all the way up to about 75%. We've finally asked, well, what would happen if we treated these mice with an oxytocin receptor blocker? And that transitioned survival essentially up to 100%. So really very clear evidence that the environment after pregnancy that is contributed to by lactation is detrimental, and suggesting a treatment strategy that could be applied to women with Marfan syndrome. We found that outcome correlated perfectly with the level of ERK activation in the aortic wall, which is high in Marfan syndrome, very high in Marfan mice that are lactating, and brought back down to baseline by removing the pups or by treating with an oxytocin receptor antagonist. On this basis, we tried an FDA-approved ERK inhibitor and found that this also led to a dramatic rescue of pregnancy-associated aortic catastrophe. So all news isn't good news. We decided to try other treatment strategies that were in place for people with Marfan syndrome. Calcium channel blockers had been considered second-line antihypertensive agents in Marfan patients unable to tolerate beta blockers in the absence of evidence for their efficacy or safety in this condition. We were optimistic. There's work in the literature that showed that the CCB amlodipine can reverse ERK activation in hypertensive rats, that different calcium channel blockers could reduce ERK activation in synergy with angiotensin receptor blockers after arterial injury. With a sense of optimism, we launched a trial of amlodipine and followed these mice with echocardiography every few months. So here I'm showing you the heart and ascending aorta of a normal mouse. Here a Marfan mouse shows splaying that's specifically at the aortic root that's buried into the left ventricular outflow tract. In a normal mouse given amlodipine, you don't see much. Perhaps the ascending aorta is looking slightly generous. But virtually every Marfan mouse given amlodipine showed hyperacute development of massive ascending aortic aneurysm, literally doubling their aortic root size within about a month, with frequent death due to aortic rupture within about 6 weeks. Contrary to expectation, calcium channel blockers actually increased SMAD and ERK activation in the aortic wall in Marfan mice. And we could block this detrimental gene by-environment interaction by treating with an ERK inhibitor. So once again, ERK appears to be the final mediator of this effect. Again, if we give amlodipine plus the ERK inhibitor, we see rescue of survival, so no more early aortic dissection. And indeed, the ERK inhibitor is having its desired effect by suppressing ERK activation. What about people with Marfan syndrome? Well, there's still more work to do here, but we partnered with the GenTAC consortium that's collecting clinical information on patients with inherited forms of aortic aneurysm. And we asked, well, was there a difference in outcome among people who at registration in this consortium were coded as taking calcium channel blockers? And the answer was that the odds ratio of aortic dissection during the follow-up period in Marfan patients taking CCBs was 12.5 compared to those not taking calcium channel blockers. This is also true if you looked at all forms of thoracic aortic aneurysm. There was also, as you might imagine, with bigger aneurysms, there was also a higher rate of aortic surgery in Marfan patients and thoracic aneurysm patients who were taking calcium channel blockers. So we do believe that there is some relevance to the people with these conditions. So overall, through this work and other work that I don't have time to go through fully, we were able to develop at least a concept of an axis for vascular disease in Marfan syndrome that involved activation of phospholipase C, IP3, protein kinase C, and ultimately ERK. The inputs included TGF-beta, included angiotensin II, included things like oxytocin. On this basis, we tested ERK inhibitors, as I've shown you, and they were dramatically protective. We've also poked and prodded this pathway in many other ways. Enzastaurin, a PKC inhibitor, was protective, as you'd imagine. That led us to the hypothesis that the antihypertensive agent hydralazine might be protective because it works at least in part by blocking IP3-mediated PKC activation. Now, this was important because hydralazine, unlike many of the other agents we've discussed so far, is known to be safe to use during pregnancy. We returned to our pregnancy-associated dissection model, and we're thrilled to see that hydralazine was dramatically protective against postnatal aortic dissection, even in mice that continued to breastfeed. So we do think that this could be considered even now for for women with Marfan syndrome who are pregnant. Much of the work that I've showed you, in fact, all of it up to this point, was somewhat hypothesis constrained. We made a series of observations, came to the next logical hypothesis, and then tested it. But we wanted to try to use a discovery-based method that could show us something completely new, that wasn't simply derivative on prior findings. And we decided to ask how nature modifies Marfan syndrome. Over the course of many years, we and our collaborators, Anne DePape and Julie DeBacher and Bart Loeys, had identified 5 exceptional families with a defined Marfan mutation, a typical Marfan mutation, that showed discrete intrafamilial variation in phenotypic severity. And by that, I mean some people with the mutation had classic severe early vascular disease associated Marfan syndrome shown as black symbols, but other members in the same family with the same Marfan mutation showed little or no vascular disease at the age of 50, 60, or 70. So we decided to use traditional linkage techniques, not to find the Marfan gene, we knew that already, but to find the protective gene that was segregating within this family and allowing some people to escape the fate of aortic enlargement or tear. So when that was performed, fortunately, in all of the families, protection segregated with markers on human chromosome 6. The result was highly significant despite the fact that we only had 5 families to work with. There were 32 genes in this interval, but one really jumped out at us, a gene called MAP3K4, which encodes a mitogen-activated protein kinase, the kind of enzyme that activates P38 and ERK. We found that people in these families that had mild Marfan syndrome had lower expression of MAP3K4 compared to families, the members of these families that had severe Marfan syndrome. We then went back to our mouse model, and in Marfan mice, we simply disrupted, we knocked out one copy of the mouse 3K4 gene and found that this was sufficient to fully normalize aortic root growth and also to normalize the abnormal cellular signaling events, including PKC, ERK, and P38 activation in the aortic wall. We also wanted to see if we could learn about modification using inbred strains of mice. So laboratory mice have been created that are extensively inbred, meaning that the mice become genetically essentially identical to each other. One commonly used inbred strain is called the black 6 strain. Another commonly used inbred strain is called the 129 strain. So we asked, are there modifier genes relevant to vascular disease in Marfan syndrome that differentiate these 2 strains? And the answer was definitely yes. So if you put a classic Marfan mutation onto an ultra pure black 6 background, the aneurysms are very small, somewhat subtle, and don't lead to early tear of the aorta. In contrast, if you put the same mutation onto the 129 mouse background, you see the rapid development of massive aortic root aneurysms with early tear due to aortic dissection. I'm showing you this on the echocardiograms on the right. It's a parasternal long axis view. The yellow arrowheads are showing the aortic root in the protected black 6 strain, and also in the vulnerable 129 strain. And you can see this really massive root aneurysm in the 129 animals with rapid tapering to a normal dimension in the more distal ascending aorta. This did not relate to anything trivial like heart rate or blood pressure that differentiated these strains. There was no difference. So if you looked at cellular signaling events, the results were not subtle. So in the protected black 6 background, you can see that there's really tremendous attenuation of the abnormal signals, including SMAD activation or ERK activation. Still a little bit increased compared to wild type animals, but greatly reduced compared to the vulnerable 129 animals, where canonical and non-canonical TGF-beta cascades are overtly activated. Now, we were able to show that even on this 129 background, with this overt activation of these cascades, the disease remained dramatically responsive to losartan or ERK inhibition. So what we had found previously remained relevant, but there were added things to learn, especially about the source of modification. So what Jeff Doyle did is he bred black 6 and 129 mice together to make mixed mice. And then he introduced a Marfan mutation and segregated the offspring based upon the size of the aorta. So some of them had huge aortas, just like the 129 pure mice. Some of them had small aortas, just like the black 6 mice. And he asked, well, what genes were consistently segregating from the protected black 6 background to the protected mixed mice? And in that manner, he was able to map 2 modifier loci in mice, one on chromosome 5 and the other on chromosome 11, that reached genome-wide significance based upon the number of markers that were utilized. So if we look at these locations in the mouse genome, you can detect numerous candidate genes that jumped out because they're expressed in the aorta, because there are sequence differences that distinguish the 2 strains. On mouse chromosome 5, there's a gene that encodes a protein called MMP17 that's known to regulate ERK activation. And there's a very dramatic sequence change between black 6 and 129, where the normal termination codon is changed to a tryptophan. On the other mouse chromosome, chromosome 11, we find the MAP2K6 gene. So you might imagine from the name, it also is an activator of mitogen-activated protein kinases. And in fact, it activates MAP3K4, which was the human modifier. So it seems that by looking at 2 different species, we've now identified a pathway of modification of Marfan syndrome. So what we did is we took the mixed mice and we gradually knocked out one and then both copies of these genes, and just these 2 genes. And we found that in mixed mice, if you simply knocked out both copies of both genes, you could make them behave just like the ultra-protected pure black 6 animals. In the mixed mice, if you just selected for normal 129 versions of just both of those genes, they behaved just like the pure predisposed 129 strain. So really clear evidence that these are major modifier genes of the Marfan vascular phenotype in mice. If you knock out both of those genes and only those 2 genes in the mixed mice, you fully suppress all of the abnormal cellular signaling events that had been associated with vascular disease in Marfan syndrome. So what about MMP17? It's a really interesting actor. It is a membrane-anchored matrix metalloproteinase, so it's an enzyme that breaks down multiple substrates. But independent of its enzymatic activity, it can also activate a receptor called the epidermal growth factor receptor that activates, guess who, ERK in the end. So we looked at the activation of the EGF receptor by virtue of its phosphorylation, and found that in Marfan syndrome, and unique to the 129 background, the predisposed background, you see tremendous activation of the EGF receptor. And that if you simply knock out the MMP17 gene, not the MAP2K6 gene, you can completely eliminate this. So our axis now is MMP17 activating EGFR, activating ERK. On this basis, we tried an FDA-approved EGFR blocking drug called erlotinib, and found that that was sufficient to suppress abnormal aortic growth in Marfan mice, and with the expected effects on cellular signaling. So I'm going to change gears here for the last few minutes of the talk and speak about my least favorite vascular connective tissue disorder called vascular Ehlers-Danlos syndrome. This is caused by a deficiency of a molecule called type 3 collagen. These patients show aneurysms and tears of any muscular artery throughout the body. The aortic root is not particularly involved in this condition. There's a high risk of rupture of the arteries, even without any prior aortic enlargement, making it very challenging to monitor these patients. There's a high risk of operative complications, so surgery can be fraught with difficulty. Really, no medical or effective treatment strategy has been defined for this condition. So Juan Calderon and Caitlin Bowen in the lab went on to make mouse models of vascular EDS. One of the models with a typical vascular EDS mutation, a so-called glycine substitution, shows very rapid death due to aortic rupture, with about half the mice dead from aortic dissection by 50 days of age, and all of them dead by 150 days of age. We tried the usual suspects. These are survival curves. Untreated mice are shown in orange. We tried ARBs, had no effect on survival. Tried propranolol or atenolol, no impact on survival. We tried calcium channel blockers, as we had done in Marfan syndrome, and as we had seen before, if anything, they made things worse with more earlier and more complete death due to aortic rupture at an early age. There had been some information that a typical beta blocker called celiprolol might be particularly effective in vascular EDS. But once again, in our animal model, there was clear evidence that celiprolol accelerated death due to aortic rupture in the vascular EDS model, both in our severe mouse model and even in our mild mouse model of vascular EDS. So the clear answer was we needed new ideas. So what Caitlin did is she took a predisposed vascular segment of the descending thoracic aorta, and she profiled all of the RNAs in the aorta to understand the activation state of virtually all of the genes, and found a large class of genes that were dysregulated in vascular EDS when compared to normal mice. And asked a computer in an unbiased way, what is this telling us? What's likely to be driving this signature that we saw in vascular EDS? And the clear answer that it was that it was a G protein coupled receptor that was driving activation of PKC and ERK, our old friends. If we look at human specimens from people with vascular EDS, we see a clear signature for high activation of PKC here in the descending aorta, here in the iliac artery of patients with vascular EDS compared to control individuals. We again needed to ask whether these are just markers of disease or drivers of disease. So we tried a PKC inhibitor called robuxastorin, an ERK inhibitor called cobimetinib, and these were both dramatically protective in vascular EDS, again with the desired cellular signaling events that we had hoped for. We then tried hydralazine. Again, it should work, and it did. We were really pleased that at 30 days of age, we saw a dramatic separation with survival in hydralazine treated animals. But then the bottom fell out. Suddenly, mice were dying at a very accelerated rate, almost catching up with the untreated mice. We realized that the onset of this was occurring at around the time of puberty, when young men with vascular EDS are known to be particularly vulnerable. And when we segregated by sex, we saw that there was some of this going on in female vascular EDS mice, but it was very much accentuated in males, leading to the hypothesis that androgens might be involved. So we then gave the mice hydralazine to get them up to around the time of puberty, around 40 days or so, but then added an androgen blocking agent called bicalutamide. And that combination proved very effective at getting the mice to and then through puberty. We realized that parents would be reluctant to start a very potent androgen blocking drug in their adolescent children, predominantly sons. So we asked, well, what about the diuretic spironolactone that has anti-androgenic activity, but would be better tolerated than bicalutamide? And that combination, hydralazine plus spironolactone, was fully protective over the long term. We've now taken this out much further, and it was effective in both sexes. Both males and females showed this full level of protection. Pregnancy, again, is a time of vulnerability in vascular EDS. We could fully rescue this vulnerability by, again, removing pups at birth, so preventing lactation, or by treating with an oxytocin receptor blocker. So a strategy developed in Marfan syndrome that seems relevant to vascular EDS. So last part of the story, we found that there was dramatic differences when the vascular EDS mutation was put on Black 6 versus 129 mice, but it was the exact opposite of Marfan syndrome. Here, the Black 6 mice are vulnerable and the 129 mice are fully protected. In fact, the performance of the 129 mice was one of the most surprising and impressive observations, I think, in my career. It really proved that nature has a way of beating this disease, even when you use a very aggressive mutation. These mice just live and live and live and live despite no medical treatment, and live a full lifetime with stress, with pregnancy. Really, nothing can cause them to undergo aortic dissection. Caitlin did the same trick that Jeff did. She bred the two strains together to map the modifier. One locus jumped out, and it was the identical locus as the Marfan modifier, MAP2K6. But here, again, it's going in the opposite direction. The high MAP2K6 strain, the 129 strain, is protected in the context of the descending aorta in vascular EDS. We were able to show that, in fact, MAP2K6 is the modifier. If we knock out the MAP2K6 gene in the protected 129 background, they lose their protection. So this is the modifier. And we were able to come up with a model of how this is working. Here in the descending aorta, in this context, we believe that MAP2K6 activates P38, which then activates two enzymes that are known to deactivate PKC and ERK, so-called phosphatases. So we had a bunch of testable hypotheses. First, what we'd say is that the 129 protected strain should have high P38 activation. That proved to be definitely true. So we could say, yes, we can check that box. We would then expect high levels of phosphatase activity in the aortic wall. And Caitlin measured that. She measured the amount of these phosphatases and their activity, their velocity of deactivation, the total amount of substrate that was converted or deactivated. And that was higher, elevated in the protected 129 background. Finally, you'd expect lower activated PKC and ERK in the descending aorta of these protected mice. And that's exactly what Caitlin found. In the vulnerable mice, PKC and ERK show high activation in the vascular EDS context. In the protected strain, there's no increase in PKC or ERK activation compared to wild type mice. So really allowing us to conclude that everything is collapsing on ERK. Another prediction is that in this context, if we blocked P38 with an inhibitor, you should lose the protection. And that's exactly what Caitlin observed. So we've been able to come up with now a very similar axis for vascular disease. Notably, everything is collapsing on PKC and ERK activation. On this basis, there's now multiple therapeutic strategies that can be considered for this devastating disorder. And indeed, a company called I2 Biopharma is intending to launch a formal international clinical trial of the PKC inhibitor enzastaurin for the treatment of people with vascular EDS by spring of this year. So final slide, a confluence of observations has greatly improved our understanding of Marfan syndrome and related vascular conditions. This has revealed many promising therapeutic strategies that are either FDA approved or in clinical development. And I'd like to end by acknowledging the truly remarkable people that I have the privilege of working with every day. I don't have time to go through their contributions, but they're all wonderful. I'd also like to acknowledge my funding sources, and I'd be happy to take questions. Thank you for your attention.
Thank you, Hal, for an excellent walk through all the phenomenal work that you and your lab have done to really elucidate the underpinnings of these disorders. I think the future looks promising with regard to therapeutic interventions. We have a couple questions and we're a little bit limited on time. The first one, seems like everything revolves around the availability of intracellular calcium as a secondary messenger. Did you assay for calcium concentrations in aortic endothelium?
Yeah, so I fully agree with the observation and the hypothesis that lots of this revolves around pathways that are sensitive to intracellular calcium concentrations. Many of our interventions have predictable effects on calcium handling by the cell. We have not done direct measurements of intracellular calcium. We are exploring the cell types that are most relevant to each of these phenotypes. And we have early results that clearly point to the vascular smooth muscle cell population in Marfan syndrome and in Loeys-Dietz syndrome. But the endothelial cell population in vascular EDS. The answer is no, we have not done this yet, but we're developing the knowledge that will allow us to start answering this type of question.
Right, we got a couple of questions that hit on the same thing, so I'll just sort of combine those into the first. Have you looked at losartan or hydralazine in inflammatory vasculitides like Behçet's, MISC, Kawasaki, or less obviously inflammatory vasculitides like fibromuscular dysplasia?
Yeah, I mean, that's a great question. To some extent, it would be difficult to do because there are not wonderful animal models that fully recapitulate the mechanism of disease. In TGF beta has many things that it does that are problematic, but it also has many important physiologic functions. And among them is the suppression of inflammation. There are some contexts where manipulations that block TGF beta can be detrimental in certain developmental stages, or, for example, in inflammatory aneurysms provoked by chemical injury of the aorta. I think it's worth doing the experiments when good models are available, but I would not necessarily predict that the treatments for these non-inflammatory conditions would necessarily be effective or even safe in inflammatory vasculopathies.
All right, we'll make this the last question from Dan Bernstein, who I'm sure you know. He's asking about bicuspid aortic valve, and recognizing that notch mutations are present in certain cohorts of patients with BAV, and that there's crosstalk between notch and TGF beta. He wants to know, should we be intervening with ARBs, beta blockers, or other drugs earlier in these patients? What your thought is on that?
Yeah, so lots of folks have dedicated lots of effort to try to identify the genes for bicuspid aortic valve with aneurysm. There are a handful that are known, including Notch1, for example, but they account for less than 1 to 2% of patients with these conditions. So by and large, that's a family of or a grouping of conditions that is not well understood. We did recently work out the mechanism by which calcium channel blockers aggravate the ascending aorta in Marfan mice, and it does involve suppression of notch signaling. If you block notch signaling in the calcium channel blocker treated Marfan mice, the disease is much, much, much worse. So we've learned that even in Marfan syndrome, notch is protective in the ascending aorta. We do know that in that context, ARBs are very, very protective. In the low notch signaling state, the ascending aneurysms can be fully prevented using ARBs. Our approach is to try ARBs in people with ascending aortic enlargement, for example, those with bicuspid aortic valve. But there's lots more work to do to decide which populations, will be responsive to that treatment. But I don't think there's much of a downside. The therapy is so well tolerated that we generally give it a try.
Yes. All right. Well, thank you, Hal, for, again, a great grand rounds today, for elucidating all the pathways that you have and all the work that you've done. It's really been an honor and privilege, and also thanks for the time to get to speak with you this morning. Thank you, everyone, for attending.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.